Welcome to the Maternal Wealth Podcast, a space for all things related to maternal health, pregnancy, birth, and beyond. I'm your host, Stephanie Theriault. I'm a labor and delivery nurse and a mother to 3 beautiful boys. Each week, we dive into inspiring stories and expert insights to remind us of the power that you hold in childbirth and motherhood. We are here to explore the joys, the challenges, and the complexities of maternal health. Every mother's journey is unique, and every story deserves to be told. Please note that this podcast is for entertainment purposes only. It is not intended to replace professional medical advice, diagnosis, or treatment. Always consult with your healthcare provider for medical guidance tailored to your specific needs. At Maternal Wealth, we aim to ensure that you have access to the best and the most appropriate care. That's why we created a maternal healthcare provider database. Maternal health providers can easily create profiles to promote their services and business, helping to increase access for those seeking their care. This is a one-of-a-kind database that offers a new and exciting way for women to search for and find maternal health providers near them and tailored to their specific needs. Profiles feature badges that highlight various services such as TOLAC-friendly practices, all-female practices, LGBTQAI+ inclusivity, language options, access to vaginal breech services, and more. Additionally, be sure to check out our Not Your Average Birth course. In this course, I discuss the variations that exist in hospital practices based on policies, staffing, and budgets, all of which can directly affect your birth experience and outcome. Are you ready? Let's get into it. Today, we welcome Anissa Sartini. They is a certified professional midwife and a licensed midwife based in Texas. Anissa earned a Bachelor of Art degree from Smith College, where they studied biology, herbalism, and various topics related to midwifery practice. Since 2009, Anissa has attended over 450 births, including in the home, birth center, and hospital. Their experience encompasses VBAC, which is vaginal birth after cesarean, vaginal breech deliveries, induced labors, medicated labors, and cesarean deliveries. Anissa is passionate about serving families in the BIPOC and LGBTQ community, working to increase access to safe and compassionate care. They live in Irving, Texas, with their partner and 2 children who were born at home in their bathtub. They have 2 cats and a flock of chickens. Anissa had both of their children through IVF. In their free time, Anissa enjoys spending time with her friends and family, creating art, and contributing to activist causes. Let's welcome Anissa Sartini.
Hello, thank you for having me here today.
Thank you for being here. First, I would like to start off by learning about your journey into midwifery.
Sure. My journey to midwifery was a little circuitous, I suppose it is for lots of folks. When I graduated high school or was about to graduate, I was trying to figure out, what was next for me. Honestly, I don't even remember how I came about learning about midwifery. It kind of came to me as this thought, like, oh, I should be a midwife. And I'm like, okay, well, what does a midwife do? What does that entail? How do I become one? And so I started looking up about how one becomes a midwife and found the certified professional midwife route, the CPM route. So basically the steps that I took were to attend an academic school. It was not an accredited one, which at the time was a lot more common. Now there's an accreditation called MEAC that's becoming more common, but at the time it was not very much heard of. And so I did this schooling and sought out clinical apprenticeships. and also obtained my bachelor's degree at Smith in a mostly unrelated subject, but also, again, like you said in your intro, took classes about, biology, herbalism, pertinent topics that would help me out. I did all that. Finding clinical apprenticeships was definitely a challenge, just because there are more hopeful midwives than there are midwives taking students, in addition to some personal challenges. I'm hard of hearing, so that was an issue for some midwives that were precepting me. Just philosophical differences, like when I moved back to Texas, being non-religious, being queer was kind of something that had to be in the closet briefly to be even able to find that kind of placement. And so eventually got through it, finished out, opened my own practice where I can be out as whoever I want to be and take care of the people I want to take care of. And that has been hugely rewarding and I think a needed voice in the community.
Why is the role of a certified professional midwife so necessary in our society today?
There's so many good answers to that question. Most of us know about 99% of births in the United States take place in the hospital, and the vast majority of those under the oversight of an obstetrician. And an obstetrician, for those of you who don't know, is actually considered a surgical specialty, which is great when we need a cesarean birth, when we need a hysterectomy, when we need the various gynecological surgeries that could be necessary in one's life. But for a normal physiological childbirth, maybe hiring a surgeon for a physiological birth is not the most logical choice, right? So in many other countries, having a midwife is the default for normal low-risk pregnancy. And those countries tend to have better outcomes for maternal and infant mortality and morbidity, while decreasing costs, increasing access. It's really a great model of care. In the United States, as far as midwifery goes, there's kind of a movement towards having more certified nurse midwives, which is a route in which you get your RN and then you go to a specialty in midwifery, which is, I think, an additional year or two of training after your RN, which is also a pretty interesting route. CNMs, certified nurse midwives, can practice at home, hospital, birth centers, depending on the state laws. Laws by state vary quite a bit as far as what CNMs and CPMs are and are not allowed to do. And so I feel like that's kind of the more popular route to go now, because CNMs tend to be covered more by insurance. They can work more in the hospital, so it's a little bit more of this accepted route. They know what a nurse is, they know they're comfortable with hospital births, things like that. So it's a really interesting route to go that way. Now, a criticism of that route and why the CPM is still important, I believe, with CNMs, typically they are under physician oversight in the hospital, so they still have to function according to the protocols of the hospital. And as far as their training, it's kind of in between. Varies vastly on where you get your training. So I've met CNMs who are very comfortable with natural birth, very, skilled in out of hospital birth, and others that are like, what the heck is that? That's scary. I only want to be in the hospital with my medications, and they don't really know much about herbs, positioning, kind of the more physiological things that we focus on out of hospital. So there's quite a bit of a range in that. So the certified professional midwife certification arose in the 70s and 80s and then didn't really gain a lot of traction maybe until the 90s and 2000s. The idea is to have kind of a little bit more of the traditional practices of a midwife. So to have that close client-midwife relationship is a big part of it, to be skilled in being able to manage emergencies outside of a medical setting, whether that means with various maneuvers, with mother's positioning, with herbs, with dietary changes, for movement patterns for the mom, things like that. And so to have that, then the certification was developed kind of for two reasons. First of all, to try to show to other providers, hey, this is a legitimate thing. We're not just showing up and catching babies without knowing anything. And also to show that to the public. Even still today, there's a lot of misunderstanding about what midwives are and are not able to do. So especially by, I think, men in particular, there's a lot of a midwife, isn't that dangerous? What is that? And, they don't know that we know how to interpret lab tests and do clinical tasks and to maintain safety while also honoring the birthing parent, while honoring the baby in a way that doesn't really happen in an industrialized hospital setting. And while we talked about the CNMs, there is the criticism of the CPM too, in as much as questioning whether it's an equitable certification. It's recently come out that Black midwives fail the CPM exam at higher rates than their white counterparts. There's not as much access to funding for schooling as there is with CNMs. So it can be harder for marginalized communities to become CPMs as opposed to CNMs, where you might be able to get grants to attend nursing school or scholarships, for example. And so that's been kind of an issue that's come to light more recently, and that's a big topic of conversation in the community currently.
I'm curious to hear, as a labor and delivery nurse, a lot of the patients bring up the idea, thank goodness they're in a hospital, because if there's an emergency, I'm in a hospital and midwives or the doctors can handle it. Common emergencies would be like a postpartum hemorrhage or shoulder dystocia, fetal intolerance to labor. What are the skills that you have in your hands to help women who might be presented with these emergencies in the home?
That's such a good question. I mean, obviously, these things do happen in any setting that birth is happening. So whether you give birth at home, birth center, hospital, these things happen. So postpartum hemorrhage, fetal distress, surgical shoulder dystocia, etc. So we are trained to handle emergencies that can come up, the vast majority of which we can handle at home. And those we can't, a crucial part of our training is knowing when we need to change plans. For example, with postpartum hemorrhage, it's a pretty common obstetric emergency. Depending on state laws and physicians that might provide standing orders for midwives, most midwives in the United States do carry anti-hemorrhagic medications like Pitocin, misoprostol. Mostly do carry things like oxygen if there's, neonatal resuscitation that requires that. And then we also have training in maneuvers, herbal medicines to help with that as well. Going back to hemorrhage, things like bimanual compression, uterine massage, using a uterine tamponade if needed. We do have methods to be able to control hemorrhage at home for the most part. A lot of us have IV skills. Let's say shoulder dystocia next. That's where a baby's shoulders can get caught coming out of the pelvis during birth. And so one big advantage that we have in an unmedicated labor and as midwives with training to physiological birth with freedom of movement for the person giving birth is that the person can move. Whereas in the hospital, I think the rates are about 90%, 80% of births have an epidural. And so there's not a lot of movement that's available. So if there is a shoulder dystocia, guess what? The obstetrician has to go in and be the hero and kind of do all the maneuvering themselves. Whereas for us, we can say, hey, mom, your baby's shoulders aren't coming. I need you to get up right now. So let's say if they are sitting, we can get them on their hands and knees. If they're in the birth pool, we'll have them stand up. And that movement, the mobility of the pelvis can help dislodge the baby's shoulders. So movement and knowledge of the physiological mechanisms of labor is not only a great treatment for dystocia, but a great prevention. So same with, if we think about occiput posterior babies, that's where, the back of a baby's head is against the mom's back to make for a harder delivery oftentimes. And so, we're able to suggest, hey, why don't we try this position? Let's try this position. And we have that power of movement to be able to help the parents get baby into a more normal labor pattern. And as far as fetal distress and labor, that does happen from time to time, but I would say it's honestly pretty rare in an unmedicated, low-risk population. Again, it does happen, but we're not doing Pitocin during labor, which can cause the fetal heart rate to be under distress. We're not using narcotic medications that can cause a low heart rate in mom or baby. It's fairly rare to see fetal distress, and when we do, we know it. So, we're so used to normal. We know normal like the back of our hand. So as soon as we see a baby that's even a little bit off of what we're used to, we're like, hey, I think we need to go to the hospital where this baby can be monitored continuously. Or, hey, this baby's really in trouble and we're going to go to the hospital and get it out right now. And I think a big benefit, because we do hear one of the biggest questions for potential clients is, well, what if there's an emergency? What do we do? Again, I tell them that most of the time we're able to handle it at home. And we always have 2 backup plans. So backup plan number 1 is most transports are not emergencies. And I think that's a big thing people need to understand about home birth. The most common reason is first-time mom that's tired and wants an epidural, for example. So not an emergency. For other things that are emergencies, we go to just the closest hospital. So if we're non-emergent, at least in our area, we're lucky enough to have a hospital or 2 that are fairly midwife-friendly. So we prefer to go to those hospitals if it's non-emergent. If it is an emergency, we just go to whatever is closest to the client's house according to their needs. For example, if it's a labor and delivery emergency, we need to go to the closest hospital with an L&D unit. Whereas if it's, say, a need for blood, that can happen at pretty much any hospital. If it's an emergency with a baby, we try to transport somewhere with a NICU. We always have backup plans.
I like how you talk about your management of labor focuses on preventing shoulder dystocia, postpartum hemorrhage, not using the Pitocin, a healthy and stable labor course and delivery. That's nice to hear.
Thank you. And we focus on that a lot in prenatal care as well. So, whereas in the hospital, I hear a lot about clients who've had past hospital births, and they're like, yeah, they didn't even really tell me how serious this prenatal complication was. And because they knew that they could handle it, like let's say with anemia. So they don't do much as far as treatment other than just talking about like, okay, well, here's an iron supplement. Or, they talk about, yeah, you should exercise, but they don't really tell you what kind of exercise you should do, what kind of daily movements should you be doing to ideally promote healthy body mechanics, to promote a good position of the baby to make for a smoother birth. We do try to do a lot of prevention in pregnancy care as well, because we know that we don't have immediate access to those things. Not only wanting to set up the client for success and the kind of birth that they want, or conversely, if things don't go the way they want, they can know, hey, you know what, I really did everything I could have done. And if it still didn't go that way that I wanted, it's not my fault. So I think that's a huge comfort to a lot of clients as well, as knowing that, hey, I was really well supported. Even if they do have to transport, they know, okay, if we did everything we could and it was truly necessary, versus the trauma of questioning, like, did I really need that? Was my baby really in danger? Is the OB just getting impatient? So they don't have to have that questioning, which I think is a huge comfort to a lot of people.
In modern day obstetrics, vaginal breech delivery is looked down upon. It's not even offered. You offer vaginal breech delivery services. How were you trained to provide this service to women?
Yeah, so I think I would add in there in the introduction that vaginal breech delivery in the United States is not very common. Vaginal breech delivery in Europe and other countries, again, where they mostly utilize midwives, and the healthcare system is not like a for-profit, liability-driven system. Vaginal breech delivery is actually quite a bit more common. As far as my own personal training with breech delivery, I was lucky enough to have preceptors that viewed breech delivery as somewhere between, a variation of normal and, well, this isn't normal, but it's still something we can support, which is kind of the view that the organization Breech Without Borders takes, is that maybe this isn't so normal, only being 4 to 5% of pregnancies at term, but it's still something that can be perfectly safe, beautiful, natural. We did have, again, I had preceptors that had that attitude of, this is something that we can do. Our bodies can give birth to breech babies vaginally. And so I had the training from preceptors, and I still do continuing education on breech birth at regular intervals. So I take Breech Without Borders trainings, done other, breech classes, just to keep it fresh. Because, as a home birth midwife, I have a pretty small practice. It's not every day that anyone sees a breech birth, even at a busy hospital. So I think training frequently is really important to maintain safety in vaginal breech. Again, mentioning hemorrhage, for example, that's something we see, I don't want to say all the time, but frequently enough that you're going to come across it. Whereas you don't see a breech baby every day. So I think that frequent training and getting very confident and comfortable with the skills needed to maintain safety is crucial. And going back to the unmedicated thing, our clients don't have epidurals they can move. And so if we have a breech baby that does need some help coming out, we are trained to do the maneuvers that we need to do, but we also know how positioning can help. Being upright with breech delivery, for example, is not only a thing that can be helpful, but I consider it a safety feature to be able to have the birther participate in the process of getting them out.
What is the main concern when women are presented with a breech delivery?
So there are several real risks that come with breech delivery, and we do talk about those. We call any process of discussion, we refer to that as informed consent. So what that means is that we give the client the information saying, hey, these are the risks of delivering a breech baby vaginally, and these are the risks of delivering any baby via C-section. So there's risks and benefits to any kind of birth you choose, but here's what they are, and so you get to make that decision for your own body, for your own baby. So the reason that a lot of providers are very afraid of vaginal breech birth is there's a risk of it's called head entrapment. So that's basically where the head can get caught in the cervix before it's fully dilated. And that could be an emergency because it can cut off, circulation to the baby. Cord prolapse is another potential emergency, which is where the umbilical cord can fall through the lap of the baby since it's not that solid diameter of the head. And that also can, cut off oxygenation, and causing damage, death to the baby. So those are the main two things that are concerns. And there are other things that can happen, like fractured humerus, the arm bone, fractured clavicles, similar to a head down shoulder dystocia. Things like that are partially, a risk of like a provider that's being really rough, but can happen just with like a regular delivery as well. You'll also hear about hip dysplasia with breech babies, but when they actually studied that, so the hip dysplasia happens in similar rates in both breech babies delivered by cesarean and vaginally. So it's not so much about having been born vaginally, it's just about the position of having been splinted like that in utero for however long amount of time. If you go back and talking again about cord prolapse, for example, it's more common with what's called an incomplete or complete breech birth. So that's where the baby is sitting with the feet kind of folded together as if you were sitting cross-legged on the floor, because the baby's got the lap that can kind of fall through. So it's more common. The good news is that it's less of a dire emergency than it would be with a cord prolapse with a head down baby, or even with a frank breech baby. And a frank breech baby is where the baby is sitting in utero with the legs like butt down, legs up together, feet up by the head. And that's considered a safer method of breech birth just because it's called the bitrochanteric diameter. So that means the diameter around the booty and the thighs is bigger, more like a head. It's often about the same size or even bigger than the head diameter. So if there's a cord prolapse with a frank breech, yes, that is dangerous, but it's also less common. It has more similar rates to a vertex, like a head down delivery. Again, knowing if you're a provider that's interested in attending breech births, then knowing the difference between those rates of risk. When is this an emergency? When is this hey, this is an emergency, but we've got a few minutes, right? So, yeah, just knowing the difference between those types of emergencies, when are they more likely, when are they less likely? I think that's very important.
You, as a midwife, can anticipate when labor is going on the right path. And most of the time, there's subtle signs, right? That, okay, something is going array. It's not dramatic that, okay, all of a sudden, like we need to have a stat C-section. Generally, you can see that this is going in a way that it might need to go to the hospital.
And we definitely try to not wait until it's a dire emergency. One complaint that, especially when I was first starting out, before anyone even knew what midwives were, is very unaccepted, is that midwives would wait until it was a train wreck and bring them in. And now, thankfully, at least in my area, it's not so much like that. There's more acceptance. We can bring in a client earlier in labor and be treated with a modicum of respect, at least. Because one thing that OBs don't like is they hate being brought those train wrecks. Like, why did you wait so long? Why are you showing up and all of a sudden giving us your problem? So we try not to do that. We try to, like you said, watch for those subtle signs and say, hey, something's not quite right here. Like we do as midwives, we give report to the hospital that we're bringing the client to and saying, hey, here's what's going on. Here's what I think needs to happen. What do you think? Here's the client's preferences. We'll be heading in at this time. And yes, almost always when there is a transport that needs to happen, I will have the conversation with the clients to say, hey, for example, your baby's heart rate is looking a little concerning, and I would like to go now rather than waiting until your baby's really in danger and having to have this be an ambulance ride. So let's go ahead and make this happen now before it is a dire emergency.
I want to talk about maternal health care in Texas post the reversal of Roe v. Wade. In your practice, what changes have you seen with patients in your care?
It's been really sad. It's been difficult. So, as I said earlier in the interview, I have a small practice, so you wouldn't think that I would be seeing the repercussions of this very much, but we already are. I would say the main way that I have seen this affecting folks, two things. If you have a fetal malformation where you're choosing to terminate because the baby's, for example, not compatible with life, then having to jump through all these hoops, leave the state, have providers that are afraid to even tell you what to do because of the laws about anyone, the wording is aiding and abetting an abortion, left vague on purpose. So that's been interpreted as anywhere from saying to a client, I would recommend that you terminate, or you have the option even to terminate based on health reasons, all the way up to actually performing an abortion. All of that is illegal now. It's been really sad to have to see clients suffer not only through the loss of this wanted pregnancies, again, either from fetal malformation and choosing to have an abortion, or clients that have miscarried and everyone's afraid to treat them or in the process of miscarrying because, well, if I do a D&C, if I prescribe misoprostol, am I going to be charged with performing an abortion? Mm-hmm. And again, in my practice, I'm largely seeing clients that these are wanted pregnancies, even planned pregnancies. And so it is so tragic to see them going through this process of being refused to be treated, having to travel for care, being treated like they're lying by hospital staff. Like I had one lady who actually did an IUI for her, an intrauterine insemination. Very wanted, very planned pregnancy. She miscarried and just had the hardest time finding anyone to help her because, when she went for an ultrasound, no heartbeat. And they're like, well, you could just be not as far along as you thought. And she's like, no, I know the day I got pregnant, I have the documentation, the baby's died. And just no one would help her. So, okay, well, you can get an appointment for, another 2 or 3 weeks. And she's like, I don't want to sit here with my dead embryo inside me for another 2 or 3 weeks. Like, I want to, be able to process and move on with this situation. Yeah, so it's been really sad. Yeah, and, as midwife, we don't do abortions, even though historically that's been part of midwifery care. And I do believe that CNMs, we talk about the nurse midwives, a lot of them I think can receive abortion training, at least in other states. I'll just say it's been difficult and sad trying to help these folks going through this already difficult process.
It's hard to hear. I'm all the way up in Massachusetts, so I'm in this little bubble and I know what's going on, but hearing it from somebody who's seeing it on the front lines with your patients, it's hard to hear.
Yeah, another issue that's coming up is that Texas in particular has already had pretty poor infant and maternal mortality rates for a variety of reasons. Racism, poverty, lack of access to care. And with these new restrictions, research is showing that a lot of clinicians don't want to be here because of things like that. And new doctors don't want to move to Texas because they want to be able to provide care for their patients. They want to be able to save their lives if they're having, for example, sepsis from a pregnancy who technically still has a heartbeat. So they have to wait until the embryo has passed before they can do anything to save this adult woman's life. And people don't want to do that. And so the scarcity of providers is getting worse. As far as midwives, out of hospital midwifery is not covered by Medicaid. Most insurance does not cover it. So even providing, again, like normal pregnancy care to people is hard. They call them maternity deserts. It's I don't want to be, depressing, but it is. It's very depressing, and it does not look like it's going to be getting better anytime soon. There is advocacy work trying to make things better, but our maternal mortality review board was even just shut down in light of these changes. So it's kind of like, okay, look away and it's not happening. So yeah, it's hard. It's real hard.
Talk about getting septic and waiting. I just can't even imagine being in the hospital and seeing somebody actively dying who does not need to be actively dying, not being able to save her.
Yeah.
What that would do to me as a person.
Yeah. Yeah, same. I mean, I'm not a hospital provider, so I'm not usually in that circumstance, but I can imagine that if I were, it's like, oh my gosh, I mean, you would almost rather lose your license than let somebody die.
Right.
Yeah, it's a terrible, unfair position to put physicians in. Absolutely. I mean, as much like criticisms as we have of the obstetric system and everything, like obviously they're there for a reason. And when there's complications, boy howdy, are they great, right?
Right.
And so putting them in that position is completely unethical and unfair.
Want to take a little turn and talk about something that brings me joy, and I'm sure it brings you joy. I would love to hear the birth story for your 2 children.
Yeah, I could talk about that all day.
Okay.
Definitely a much happier topic. So let's see. Yeah, pregnancy. We can start with that because that was certainly a journey. So I have a wife. That's makes things a little more complicated to get pregnant. Yes, she is trans. We do have the material, so to speak. And so basically we kind of tried, at-home methods for a while. Being a midwife, being super familiar with fertility awareness and everything, I was like, okay, after, 6 months or so, I'm like, this is not working and it should be. So I knew when it was time, just like in pregnancy and birth, we know when it's time to seek higher care. So at that point, I was like, okay, I think we need to see a fertility specialist. And sure enough, found out that we both had some fertility issues. Her, with even before any HRT or anything, had like low sperm parameters. I had low egg reserves for my age. And so there just wasn't a lot of chance of them getting together. And so, again, after discussing the risks and benefits with our provider, we decided to go ahead and do IVF so we would have embryos for the future. We always thought we wanted, more than one child. I think it helped too that our provider was a gay man, so having that cultural competence is really nice. And so, yeah, we decided to go through with the IVF process, and thankfully were successful on the first try. For those of you who are not familiar with the IVF process, of course they merge the egg and sperm in vitro, and then you can do testing to find out, how many survive the development process, how many are normal, how many are abnormal. So we were very fortunate. We had about half normal, half abnormal embryos. Thankfully, I got pregnant on the first try. I did have, with both of my pregnancies, it's called a subchorionic hematoma. So that means basically bleeding that happens behind the site of implantation. It was a scary process, especially the first time. I mean, even knowing what I know there's like a 70% survival rate of pregnancies with subchorionic hematomas, for example. But as awful as it is to say, like if you've gone through fertility treatments, that pregnancy is so precious. Not that every pregnancy is not, but it's not just like okay, you can go have sex again if you miscarry. It's like, okay, there's another, $4,000 out the window. and work so hard, plan so hard. So it's a really big emotional impact when you're scared for those pregnancies. And again, big financial impact. Again, thankfully everything ended up fine. But yeah, both of my pregnancies were pretty uneventful, healthy up until the very end. With both of them, I did develop some hypertension. Nothing terrible, enough to where we were keeping an eye on it. With my first, I carried to 41 weeks and went into labor spontaneously with her. My midwife was a friend of mine who I actually had been her midwife a few years ago, so it was super, super special to get to reciprocate that relationship with her. I just love her. Yeah, I had her for my first birth. Yeah, I went to 41 weeks. Had done some stuff to stimulate labor. So I'd had a couple membrane sweeps and doing some herbs and nipple stimulation and stuff like that. So anyway, morning of week 41, I went into labor very gently, peacefully. Just kind of spent the day doing stuff around the house, hanging out with my wife and our cats. And it was great. Took a nap, woke up later on in heavier labor. Had a video call with my friend. Just, it was great. It was very like nonchalant and peaceful, while at the same time being very sacred and sweet. I had a pretty easy labor process with great support from my wife. Let's see. Yeah, eventually called back my midwife in the evening when things were getting more intense. So yeah, she came back and I was like 8 or 9 centimeters, and I'm like, woohoo! I'm about to have this baby. This is great. This is not as bad as I thought it was gonna be. And then pushing was really hard for me, unfortunately. So
Really?
I had a really prolonged prolonged pushing stage, like 5.5 hours. It was a while.
Yeah.
For those of you listening, a normal pushing stage for a first time mom is usually like an hour or two.
Mm-hmm.
So having it be that long, and again, knowing what I know, I'm like, what the heck is going on? Like, why isn't the baby coming down? Why is this taking so long? And going through the things in my head, like, oh, I'm just in arrest and descent. Like, oh no, like, what are we going to do? And
Mm-hmm.
I've come so far. And it was also May 2020, right? So right in the middle of COVID there. And I'm like, I don't want to go to the hospital by myself. No, I'm staying home. I'm getting this baby out here. So I definitely had that mental resolve of, yeah, I'm not changing my plans. I'm going to have this baby. But also the desperation of, well, what if I can't? Why isn't this working? And so we tried all the different positions, water, land, everything. And eventually I remembered I have a massage therapist friend who had offered to come in labor if I needed it. So my wife was like, call her! She called her and she didn't answer, and I'm like, and she told me so, and I'm like, call back! So she called back, massage therapist friend came and did her magic, and then all of a sudden I felt the baby moving again. And I'm like, she's coming down! This is great! And so, yeah, my friend adjusted me when I was in my bathtub, and I felt my baby starting to move down, and then just got this great, euphoric blast of energy, like, okay, we're really doing it now, and just focused on my power and got them out. I caught my own baby, which was so awesome. Yeah, in my own bathtub at my own home. That was so incredible. It was just the best, most blissful experience. There's even a picture of me like smiling as they're crowning. I'm like, it's great. It was so amazing. Then I did hemorrhage after I gave birth. So after that prolonged pushing stage, I think my uterus was just real tired, and we waited for the placenta to deliver. They gave me some misoprostol, and I delivered the placenta, gave the baby and the placenta to the wife, and was just, pretty woozy at that point.
Mm-hmm.
But yet it felt safe. I knew that I was hemorrhaging. I knew that my baby was with my wife. I knew that I was in good hands, that if it got out of hand, I would be taken care of. They were treating me in a safe, respectful manner, in a safe, respectful environment. Even with, there were, 2 complications with that labor, right? So an arrest and descent and a postpartum hemorrhage. And yet, it was such a positive experience. It was so empowering. It was so personal and beautiful that I think it will always be one of my favorite things I've ever done.
I love that you were able to have even with the complications, you felt safe. You had a competent midwife who was taking care of you. And even with the complications, you were taken care of at home and everything turned out okay.
Thank you. Yeah.
I'm curious about your friend massage therapist. What areas did she target on your body?
Oh man, she wrote it all down for me. It was so funny because I've seen her during pregnancy too. I remember, she always explains what she does while she's doing it because I think it's interesting, right? I remember she was doing her stuff and explaining what I was doing. And I remember thinking to myself, I don't care. I don't care what you're saying. Like, just do it. I was like, felt guilty for it because I was like, oh man, like, I'm usually so interested, but this, I just can't listen right now. She did something with my back, my sacral area, and I think lumbar spine too, and then also released something near my pubic bone. I remember her saying to my midwife too, like, hey, you should feel this. And the midwife was like, wow, and like, because she had felt the pubic bone move, and that's what, the baby needed for them to be able to emerge. I'll have to look it up and send it to you. I think she wrote it all down for me.
Yeah, no, I'm curious.
Yeah, and that's another thing that, like, this is such a pipe dream. Like, this is never going to happen. But wouldn't it be so great if in labor and delivery units they had, like, chiropractors and massage therapists? And they're starting to at least have nurses that are trained in spinning babies so that for every arrest in labor, for every failure to progress, rather than say, like, okay, well, here's some Pitocin or here's a C-section, that's basically all we got. If they had body-aware workers that could help moms get through these things, and imagine like how much less it costs to hire an LMT than an anesthesiologist, right? I think it'd be so amazing, but maybe in the future.
Maybe in the future. I think the more women learn about these types of services and how it can be beneficial to them in preventing a C-section in the hospital, women have the voice and collectively they can make change. That's one of the great things about this podcast, is to give this kind of information to women before they get into the hospital so they have resources and they can advocate for themselves.
Yes, I sure hope so. Yeah, and if you want to, I can tell a little bit of my second birth story.
Yeah, no, we're good. I would love to hear it.
Okay. As most folks, my second birth was a lot quicker and easier than my first. Pretty textbook. I mentioned that I had started to develop some hypertension at the very end of both pregnancies. And with the second one, I was like, I think I'm ready for this to happen. They were 40 weeks on the due date. And so I decided to contact my nurse midwife friend. And I was like, can you do a balloon catheter on me? And she's like, sure, come on in. So I went to see her and she gave me the Cook's catheter, and I had done the castor oil burrito in the morning. And so when I left from the balloon induction appointment, I started having contractions like every 10 minutes. I'm like, okay, cool. And I was driving home thinking, okay, I hope it doesn't get too much stronger while I'm driving. And thankfully made it back home just fine and dropped into the most beautiful labor. Again, my midwife was different this time just because my old midwife had moved. So my midwife this time was actually a former student of mine who had graduated. And that was awesome to really see her performing in her prime and knowing I was with someone that practiced similarly the way I do. I was just so full of pride to have her there, so full of joy to have her be my midwife. And yeah, I basically had a really sweet 6 hour from start to finish, 4 hours of active labor. It went pretty fast. At some point, I did ask to be checked. I was feeling, more pressure. And they told me that I had a swollen cervix. And I'm like, no, because we all know that swollen cervixes can sometimes take quite a while to resolve. Again, I was feeling a lot of pressure. So I'm like, oh my gosh. Like, I will say I went into a lot more despair than I think I did with my first labor, even with the arrest and descent. But there was probably like 40 minutes there, according to the chart. Of course, it feels like forever, where I'm sitting there like, because it went from this like, bliss, like unity with the universe, like I'm totally in my rhythm, to like, oh my gosh, maybe, how am I gonna have this baby? I wish I were dead. But maybe I haven't had the baby by 11 p.m. I'm gonna get an epidural. Like all these, the irrational thoughts that come in transition. And my midwife talked me through it. She's like, "You're okay. Like, just wait it out a little bit. You're gonna be all right. Your baby's fine. You're strong, blah, blah, blah." All the things that we say to each other. And so, yeah, I waited it out for, again, it felt like forever, but it turned out it was only like 40 minutes. Then at some point, I'm like, okay, I gotta do something. Like, something needs to give. And I don't even remember this, but apparently I asked for another cervical check, and she was like, "Oh, well, now you've just got like a little lip." And she
Okay.
tried moving it back for me. And then I was like, not having it. And so I just did it myself. So I just reached in and, grabbed what was left of my cervix and pulled it over my baby's head for a few contractions. And then it was gone. Yeah, I was like pushing her beautifully, super strongly. And I definitely did not breathe my baby out. But yeah, it was super strong. And I even had this like image in my head as I was pushing of like, like the old like Williams obstetrics textbooks that show like these illustrations in black and white of the cardinal movements of labor. So I'm like picturing them in my head as they're happening. Yeah, then same thing. Like she was born in the same bathtub as big sister, and I caught the baby. And one thing that was different about the second one, I pushed, got the head out, and I wouldn't say a shoulder dystocia, but a little bit of sticky shoulders. So, the head came out. I knew to wait a minute. So I waited a minute, felt the urge to push again, pushed some more, and I was like, why isn't the baby restituted? Where's my external rotation? And I'm like, noticing this, and I'm like, she's not coming, like, get her out, get her out. Things that people say. And my midwife is like, can you stand up? Like, let's get this baby out. And I was like, no, just get her out. And so I knew my midwife had the skills to maneuver the baby out. I talked so much about movement, but wouldn't do it when it was my turn. For me, that was part of my like emotional process, was like being able to let go and let someone else help me, let someone else, I don't want to say be in control, but again, just to help, to feel protected for that moment. And yeah, the midwife reached in and maneuvered the shoulder, and the baby was born just fine. Again, I helped Kat, brought the baby to my chest, and it was super blissful and empowering and great. Again, even if there was a slight blip in the process, yeah, it was wonderful. And I did have a bit of a hemorrhage again, but I handled it better than the first one. It wasn't as dramatic because I had asked for what's called active management with this one. So active management means that you get a preventative shot of Pitocin to prevent excessive bleeding after birth. So I had asked for that, got that this time. And yeah, they were both super empowering, super sacred, beautiful experiences. I really wish that everyone could have births like that. Maybe they weren't perfect, but they were perfect for me, in retrospect. I felt protected, honored, seen, and safe. They were beautiful. I wish that everyone could have births like that.
Did you have any tearing during your deliveries?
My first one, no tearing whatsoever somehow. I was very, very patient, and I felt what words were allowed to say on podcasts. I was like, oh my God, my clit's burning, my clit. And like that midwife brain, I'm like, okay, I better push really slowly because those periclitoral and periurethral tears are real hard to heal, so you better go slow.
Mm-hmm.
And so I went like really slow and patient and like delivered her head really smoothly, and yeah, no tearing with the first one. The second one, I wasn't quite as patient, and so I did have a teeny little, like tiny little mucosal tear.
Okay.
Let's see, I think I asked for, just a tiny labial scrape type of thing. So I had some surgical glue on the labial tears, and then the little vaginal mucosal one, it was so small that we didn't really do much with it. And in retrospect, I kind of wish we did, but also I think I wasn't patient enough healing, because I think it mostly healed. And then, to be honest, trying to have sex with a different male partner, like 6 weeks postpartum, it like opened up again and gave me some trouble for a few months. So that was not the best.
Final question. What advice would you give to women who are interested in learning more about having a home birth?
I would say learn about all your options. So depending on what area you live in, you may or may not have a lot of providers to choose from. Like in my area, in the Dallas-Fort Worth area, God, there's probably over 100 midwives. There's so many people to choose from. So, don't interview all 100. Read people's websites, see who you resonate the most with, and schedule some interviews. You don't have to hire the first person you talk to unless you just see the one, their website just speaks to you. Yeah, like see what your options are. So find someone who's, culturally, personally a good fit for you. Find someone who practices the way that you would want to be treated. So that means different things for different people. Like, for example, for me, I wanted somebody who would be willing to push the limits a little bit if there was an unusual situation. If I had a breech birth, if I had with my hypertension, I wanted someone who would be comfortable trying to treat that naturally within safe limits and not just immediately transfer me. Whereas other people might want to feel more anxious, might be like, hey, I want to be sent to the hospital at the first sign of something going weird. So finding a provider that's going to honor your preferences for treatment, what are reasons that you might transport for, would be a good question to ask. And what risks me out would be a good question to ask. For a lot of people, these pregnancies are unplanned maybe, or maybe you planned it, but all of a sudden there's all these options. It's like, I don't know what I want with all these things. So I think taking a childbirth class is really great. Having a doula is great if you can. But, financially, sometimes it's hard to have both a home birth midwife and a doula. But yeah, finding someone who really resonates with what you want, how you want to be treated as a person. Even, we were talking about abortion and things like that. I've had a lot of people who specifically do hire me because if that became necessary, I want a provider who's not going to judge me for that if it comes down to, saving my life, or it comes down to having a child that's not compatible with life and supporting their choice to have an abortion. So finding someone whose values are the same as yours. Or conversely, if there's some people who, let's say, are very religious and don't want that to be part of their care, who want prayer or things like that to be part of their care, and that's fine too. And so try to find a provider who can do that for you. Yeah, there's so many options. Yeah, knowing how you would like to be treated as a person and as a patient.
Thank you so much for taking time out of your busy schedule, leaving your little newborn to come and chat with us. Thanks for being open and honest with us. And lastly, I want to thank you for doing what you do in creating a safe space for women to come to you and seek reproductive care and maternal health in the way that they see fit for themselves and giving them autonomy over their bodies. So thank you for doing what you do.
Yes, you're very welcome. It's an honor to be invited into those spaces and to be trusted with someone's care in the perinatal space. So yeah, it really is. It's lovely to be able to provide a safe feeling for people that might not feel safe in a standard, hospital setting. So it's really an honor.
Absolutely. Keep doing what you're doing. We need it.
Oh yeah, I wanted neither here nor there, but one more fun detail about my second birth. It was on Leap Day.
That's awesome.
Yeah, so I had this really magical experience to get my little leapling.
Yeah, that's so cool. I love it.
Thank you so much for having me here today, and I hope that this has been educational for anybody listening, and I hope that it inspires you to find the practice and method of birthing that is right for you, whether that be home, birth center, hospital, but someone that you just love, that loves you and cares for you.
And if you're interested in learning more about Anissa Sartini, I'll have a link to her website. So if you want to reach out to her directly, you'll be able to do that.
Thank you. Yes, we're with Metroplex Midwifery. So you can find us metroplexmidwifery.com or Metroplex Midwifery on Instagram or Facebook. People keep telling me I need to get a TikTok, so I guess I need to because that's what the kids are into these days.
They're going to be having babies too, so.
That's right.
All right. Well, thank you so much. We'll be in touch.
All right. You bet. Have a good one.
At Maternal Wealth, we aim to ensure that you have access to the best and the most appropriate care. That's why we created a maternal healthcare provider database. Maternal health providers can easily create profiles to promote their services and business, helping to increase access for those seeking their care. This is a one-of-a-kind database that offers a new and exciting way for women to search for and find maternal health providers near them and tailored to their specific needs. Profiles feature badges that highlight various services such as TOLAC-friendly practices, all-female practices, LGBTQAI+ inclusivity, language options, access to vaginal breach services, and more. Additionally, be sure to check out our Not Your Average Birth course. In this course, I discuss the variations that exist in hospital practices based on policies, staffing, and budgets, all of which can directly affect your birth experience and outcome. Please follow us on our social media platforms at maternal_wealth on Instagram and Maternal Wealth on Facebook. Visit our website at www.maternalwealth.com to sign up as a maternal wealth provider or search for maternal wealth providers near you. Lastly, check out our birth course, where I discuss how hospital staffing, policies, and access to medication can affect your birth experience and outcome. Stay strong, stay empowered, and remember, you got this.